Hello, everyone. Thank you for your active participation in the discussion board. And it's good that you as students are also interacting with each other on the discussion board and sharing your thoughts and ideas, which is great. I just thought that for your queries, it would be easier for me to talk through and explain certain concepts which you had inquired in the discussion board rather than write them down, because writing would not make 100% sense. It would be easier for me to explain them to you, which is why I have made a couple of slides to address the queries which you had on discussion board. So now with furosemide, which you have learned in your case study about malnutrition, yes, there are two mechanisms which are going on, and you are spot on right. One of them is dehydration. So what is happening over here? When you are having furosemide, when the patient is having furosemide, there is a lot of excretion of urine. All right. So what is happening? You have low volume or low solvent concentration, and your solute concentration increases. So remember the concept of osmosis. Your liquid is going down, but the solid particles in the liquid, they are going up. Okay. So low volume and you have high solute concentration, and this could lead to high sodium. All right. So yes, one is lot of excretion of urine, okay, elimination of urine, and this can cause dehydration, and dehydration could in turn be a reason of high sodium concentration. So that is one thing. Second, furosemide is a medication. It is a drug which is having an intention to excrete excessive amount of fluid, excessive amount of electrolytes, which are your sodium, potassium, chloride, all of those electrolytes. Okay. So yes, it is working in this way. But now, why are the GPs more concerned with potassium being overly excreted rather than sodium? Why? Because potassium is an extracellular ion, and its elimination is much more faster, much more in higher concentration than compared to sodium, which is an intracellular ion. Okay. So yes, there are two things going on. Why is sodium higher for the patient, the malnutrition patient? First thing, it could be dehydration. Dehydration because there is a lot of elimination of urine. Okay, so diuresis, this is a diuretic drug. But then on the second hand, is he having enough amount of fluid to replenish this excessive loss of fluid from the urine? The food record chart is questionable. It does not give you the fluid intake of the day. The fluid intake, if you calculate from the diet that the patient is consuming, is certainly not enough. Okay. So yes, dehydration, definitely one cause as to why the sodium is higher. Sodium could also be higher because of basic osmosis principle, where you have lot of fluid loss and your solvent concentration is increasing. Okay. Yes, furosemide as a drug is intended to eliminate and throw out fluid and electrolytes. And yes, you have excretion of sodium as well. It is not that you do not have excretion of sodium at all, but the way sodium and potassium work in the body, there is always going to be more excretion of potassium in the ratio of comparison to sodium. Okay, so I hope that makes sense, which is why if you remember in the discussion when we did in the class and I shared the discussion answers with you, this is the line which I had in the document, which is, yes, the sodium is high. There could be suspected dehydration, which is my first cause, okay, which is my first suspect. And that is what came across your discussion board as well, that yes, you suspect dehydration. And secondly, it could also be that the proportion or the ratio of potassium excretion is higher than sodium. And you know the reason why this could happen? Because of the nature of the ion, intracellular versus extracellular. Okay, so I hope this makes sense. And very important fact that I want to share with you guys is that when certain things happen in the body, they don't happen in isolation. Okay, so the reason of dehydration is not the only one. There are multiple factors which are playing into force. Which factor is more predominant than other? Is it dehydration, which is a much more solid reason for the high sodium concentration? This is something which we would need to have both data, which is fluid output versus fluid input. When you have limited amount of data in your case study that is provided, and which is what real life is about, when you look at medical cases, you do not have all the data that you need until and unless you're physically there running about, talking to the nurse, talking to the patient, and then collecting extra data. So when this is not possible, when you have limited amount of data, which is when you use terminology such as suspected dehydration, because you have the fluid record chart, you have the food and beverage intake, but you do not have the water intake recorded in the fluid record chart. You don't know how much the person is drinking, right? And you do not have the urinary output chart, but you do know that furosemide is a drug which causes diuresis. Okay, so suspected dehydration can definitely be one of the strong causations. So if you have these terminologies in your, say, answer paper, which is suspected dehydration, high potassium excretion in comparison to sodium because it's an intra versus extracellular ion, if you have these words written, meaning, yes, your thoughts are in the right direction. Okay. So I hope this makes sense. Remember, multiple factors play in role. Secondly, when you do not have all medical information present, use terminology such as suspected dehydration, because this shows that you're thinking in the right direction. And then in real life, what you do is you actually collect that information which is missing. You speak to the nurse, you speak to the patient, you speak to their carer and get more information. So I hope this is clear, guys, the concept of furosemide in your discussion query. Moving ahead. Yeah. So one of your discussion queries was on texture modified food and how would this be assessed in, say, an assessment or in an exam. So firstly, let me tell you that you will learn a lot more about texture modified food when you come to your CVA lecture or stroke lecture. So bear a few more weeks and you will get a lot more information on this. Okay, right now it is just briefly mentioned to you or flagged to you. Now, let me tell you a few FYI information before we come on to the part as to how is it going to be assessed, for example. Okay. So yes, texture modification in Australia is done by a speech pathologist. So the speech pathologist actually tells you what is the level of texture which is required. Is it level 1, 2, 3, thick, medium, moderately thick? So the speech pathologist does that assessment. In Australia, you as a dietitian, you are told by the speech pathologist that, look, this person needs, say, level 3, say, moderately thick fluid. So they tell you what is needed. And then you ensure as a dietitian that you are providing a nutritionally balanced, requirement for the patient, and you're meeting his nutrition requirement in his modified texture that has been prescribed to the patient. Okay. Just as an FYI, in Canada, dietitians are actually taught to undertake texture modification assessment. Okay. So you are taught to decide what will the patient need, thick, thin, moderately thick, what will he need? So you do the actual texture modification assessment. All right. But that happens in Canada. Over here, you don't do the assessment. You are told what the assessment outcome is, what is the level of texture that the person requires, and then you have to make sure that the nutrition side of it is complete and balanced. Okay, so the nutrient requirements are being met. So now, coming on to the question as to how would something like this be assessed in your exams or in your assignment. Of course, I was going to talk more about this when you had your CVA lecture done, when you had your coming lecture done, which is, say, on oral nutrition supplementation, and you have a bit more idea about supplements, and you have much more understanding about texture modification from these, these lectures. Okay. But so if this is a bit ahead of you, if you feel you do not understand this, be patient, give yourself a couple of weeks. You will be taught a lot more in this space in your coming lectures. And then maybe you can come back to this recording and it may make a lot more sense to you. Okay. But yes, one of your teammates have asked this question. So it is good for me to share this information with you, but if you don't understand it, don't panic. Just come back to it a bit later. All right. So for example, if you have a question such as, say in your assessment, Mr. William is told to consume a consistency. So he's told by whom? Speech pathologist, obviously. So Mr. William is told by a speech pathologist to consume a consistency that quickly pours from a spoon, but slower than a thin drink. Okay, so this is what the speech pathologist has identified. So which supplement, okay, which oral nutrition supplement will be suitable for this patient for his swallowing assessment? So for this, I would encourage you to read your chapter in your handbook on texture modification, which starts from the page number 231. And if you see, I have actually taken this terminology, quickly pours from a spoon but slower than thin drinks. This is actually taken from the handbook for a particular level of assessment. Okay. So now I won't tell you the answer, but probably you can share with me in the workshop. I have given you two options and one of them is right. Okay. So which sort of oral nutrition supplement would be good for Mr. William according to this assessment, which is quickly poured from a spoon but slower than a thin drink? Nutricia Forte Cream Complete Moderately Thick Level 3. Would this be an appropriate supplement for Mr. William to consume according to his swallowing assessment? Or would it be Resource Thicken Up Clear Mildly Thick Level 2? Okay. So now you have to tell me what the answer is for this. And if you get it wrong, as I said, be patient. You have not learned about oral nutrition supplements. You have not learned about texture modification in detail. All of this is coming in your coming lectures. But I did not want to answer this query because it was a good query, but you can always visit this later on. But yes, if you figure out what the answer is, or at least take a guess and share with me what your answer is in the workshops. Okay. Then moving on ahead. So yes, guys, now when we spoke about grapefruit, just to clarify, one of your teammates had said, is this to do with sodium ions and stuff like that? No, this is a completely different query. This is an informal chat that we had in the workshop where I told you about. If you look at your medication section in your handbook, you will see a lot of drugs are saying, do not have grapefruit with your medication. Do not have grapefruit with your medication. So why is that? Okay. So this discussion is pertaining to that query, which is why can you not have grapefruit or grapefruit juice with medications, a lot of medications. Okay. So what happens? So now when you have, say, grapefruit juice with a medication, what grapefruit does is it blocks an enzyme in your intestine, which is CYP3A4. Okay, so this is the name of the enzyme. It blocks this enzyme. This enzyme is responsible for the drug slowly releasing into the blood. Okay, think of it like the concept of, say, simple sugars versus complex sugars. Why do we tell people not to have a lot of simple sugars, chocolate, candies, confectionaries? Because it shoots into your blood. You have such a high spike of blood sugar level. Okay, and then this can cause hyperactivity and ADHD sort of symptoms. And this can also, a lot of excessive sugar is not all converted into energy, and it is stored as fat. So it has implications on weight management, a lot of things, right? So similarly, imagine you have something which helps the medication to slowly release in the blood. This medication then can be optimally used by the body. Okay. Now what is happening? You have this enzyme which is blocked. This enzyme cannot function. So you have these gates which are wide open. So all the medication is happily going into your blood like super fast speed. Then what happens? You have too much of drug in the body, and this can cause drug toxicity. What type of drug toxicity? Some drugs can have, say, toxicity, or they are cardiotoxic. Some could be, say, nephrotoxic. Some could be neurotoxic. Some can affect your muscular system. So depending upon the adverse reaction of the drug, these are the, say, side effects that you have if you have a lot of drug toxicity, when you have excessive, say, shooting of drug in your blood. Okay, which is why you will see a lot of medications are prescribed to be consumed with food, so that there is even a slower release of drug into the blood, which is at an optimal pace for the body to utilize that benefits of the drug, okay, or the medication. On the other hand, what grapefruit also does is that it blocks certain transporters, and these transporters are important. These are protein molecules which are important for transporting the drug in the body, and then you can have good effect of the drug, okay. But now those transporters are blocked, meaning you need an Uber, but all the Ubers are taken on the app, then you just have to wait, okay. Meaning what? You cannot reach your destination in time, okay, or maybe there is too little drug which is reaching the body, and then you think, oh, the medication is bad, the medication is not effective, okay. No, it is not that the medication is not effective. Very little of it is going into your bloodstream, into your body to actually make a difference. A lot of it is just being thrown out of the body because of the grapefruit juice, okay. So there can be too much drug in the body, too less drug in the body, secondary to grapefruit, which has say interactions with the medication. And that is where I have shown you say examples of medication. Statin, which is a cholesterol lowering drug, very important medication, commonly prescribed for say CVD patients, so good for you to know about that, okay. So this can be say excessive release. Then you have this one Allegra, for example, which is say an over the counter hay fever sort of anti-allergic say drug which acts on your histamine. And this can be a very little slow release of drug in the body, and then you feel, oh, this medication is not working. No, it is not that it is not working. You have this grapefruit juice in between, which is not letting it do a good job, okay. So and guys, I have provided more references to this over here, okay, which is from the FDA, which is from, one of them is from Harvard on your discussion board. One of them is from the Australian prescribers medication list. They also give good information. One is from the NHS in the UK. So you can have more information about this, but a dietitian is a person who has to also closely monitor what medications are going into the patient's body, what is he taking, and are there any foods that I have to be mindful about while the patient is consuming XYZ medication. So that is also part of our job, is to see that the food that we prescribe or what the patient eats is not interacting adversely with the medication that he or she is taking. Okay, so I hope this has answered your discussion queries well. And I strongly encourage you to answer each other's queries as well, because this will help you to strengthen your knowledge and your confidence. Even if you answer it wrong, that's not the end of the world. I'm always there to guide you. Okay, so relax and don't panic. Okay, that's how you get through this unit. Okay. All right, then I'll see you for the next one, and I hope this is helpful. Thank you.